Dr. Premgeet and Dr. Meenu will be the PGs who will be presenting. Over to you, State President, Dr. Shamsad Begum, for the welcome speech.
And thank you, Paul. Can you hear me?
Yes.
Yes. Okay. Respected National President, Dr. Venkatagiri, our State Secretary, Dr. Paulo Rochville, our academic coordinators, Dr. Rajesh, Vijesh, and Dr. Binil. Our invited faculty, Dr. Amit Kokhli, all our senior ISA leaders, as well as senior ISA members, all other members, the faculties, dear friends, colleagues, and my dear PG students. A warm good evening, and I welcome you all. And for today's academic program, our invited faculty is Dr. Amit Kokhli. He is the Professor of Anesthesiology at Maulana Azad Medical College, New Delhi. He is a very good speaker, and he is also an orator also. And he is an active member of the ISA National Task Force. And on behalf of, and he will be presenting the topic, the clinical and the radiological assessment of airway for the anesthesiologist. On behalf of the ISA Kerala academic program, I welcome you, Dr. Amit, for this today's academic program.
Thank you so much, Dr. Shamsad, Madam, for a lovely opportunity and an opportunity rather to interact with all lovely people out there in Kerala sitting here in New Delhi. Right, that is this is again a very, very festive season going on, as I was hearing in our conference discussions, that Vishu was there, Good Friday was there, and today is a Hanuman Jayanti, auspicious day. Then we all are meeting today and having once again, thanks to the entire team of ISA Kerala, right? Other than you, Dr. Paul is there, and I have been coordinating with Dr. Rafael and there's Dr. Rajesh, for this particular workshop. And most importantly, it's an honor that Dr. Venkatagiri sir is with us today and gracing today's program. Without taking much time.
Amit, shall I continue? And then I will give you the chance.
Yeah,
okay?
Sure.
You have to complete the program.
Sure.
And today's PG Corner will be presented by the Government Medical College, Kottayam. Dr. Sheila will be the HOD. And Dr. Premjeet and Dr. Meenu are presenting their topics. And I welcome them also to this program, academic program. And I wish all of you a belated happy Vishu. And also tomorrow we are celebrating Easter. And I wish all of you a happy Easter also. And Jai ISA, Jai Hind. Okay. Now, Dr. Venkatagiri, I invite Dr. Venkatagiri.
Thank you, President Shamsad, Secretary Binil, coordinators Vijesh, Rajesh, Paul, and today's faculty, Dr. Amit, and the PG faculties and moderators. It's good that we are continuing with this bi-weekly program with the topic by the one of the renowned speakers and PGs will get benefit of it. This is, as it said, that long weekend holidays with the multiple festivals and fasting season. Maybe Shamsad has to go for breaking the fast at 6:30 and all. She is energetic, and in spite of fasting, she is energetically speaking. And hope that PGs and others will participate well. And I see Dr. Past President Dr. Narayan Naik also there among the audience. And wish that PGs will actively participate and clear doubts. Airway is more important, because if you fail spinal, it is not a big thing. But if you fail GA, you should have the airway, you should assess that. Because failing a spinal is not a big thing. I say that you have other one. If you fail in GA, you have no other alternative once you give that. So we should know more about the airway assessment and all. And it is really good to hear from airway experts. We had many experts, and more experts will be there in the future also, giving more talks on airway. Over to you, President. I see Dr. Lalit Kumar Raigar also from Airway. Welcome, Dr. Raigar also. Thank you. Over to you, madam.
Rajesh.
Yeah.
Unmute.
Rajesh,
Yeah. Hello. Without
continue.
wasting any time, we'll go to the topic itself. Dr. Amit Kohli has been introduced. He's a professor at Maulana Azad Medical College, and we are fortunate to have him because his areas of interest, one of the difficult is the difficult airway, and in fact, he was the course director for an instructor for advanced airway skills, and he has got 60 publications to its credit and 5 chapters. Over to you, Dr. Amit Kohli.
Thank you so much, Dr. Rajesh, once again. And as this topic is very, very close to my heart, and that is there because I've been conducting these kind of activities all over the country. This is there, and my talk will entirely be focusing on the postgraduate residents, right? This is a PG update, so the kind of a discussion and the kind of a level will be as per the postgraduate update, and then we can be discussing anything at the end of the talk. Right, that is there. Without taking much time, I bring greetings from Maulana Azad Medical College, New Delhi, and my very young, enthusiastic team Airway, who have been successfully conducted almost 22 workshops pre-COVID all over the country in various medical colleges. So what are the goals of the airway assessment? We should be knowing why this talk has been this thing. As we all know, as Giri sir has also said, that airway is actually, we are the airway managers. And if we are not able to manage the patient's airway, that it's kind of a nightmare, right? As he rightly said, that the spinal may fail, we can bank upon GA. But what if the airway cannot be secured, right? There's nothing left. And the highest mortality, right, from the anesthesia point of view is inability to secure the airway in elective settings, right? The morbidity and mortality percentages are really, really very high. So to all my young postgraduates who are listening to me today, right, what are the goals of airway assessment? These questions should run through your mind before you take up any patient for elective surgery. That will I be able to mask ventilate my patient? Will I be able to perform laryngoscopy directly or indirectly? Will I be able to intubate this patient? Is there a significant aspiration risk to my patient? If I predict difficulty, should I secure the airway awake? Do I have sufficient backup available in the form of manpower and gadgets for awake securing of the airway? Can I access the cricothyroid membrane if need arises? And how will the airway behave at the time of extubation? So these are the set of questions. We should have a mock drill when we take up all our patients in our operation theaters, because every patient is a different patient, right? That is there. Sometimes airway seems to be easier, but when we handle this kind of an airway, it becomes an unanticipated difficult airway. But if you run through this mock drill, these set of questions in your mind, right, you are likely to succeed because you have planned yourself, right? That is particularly there. Whenever you are dealing with a case, right, after running the mock drill, make a plan in your mind, right? This is how I am going to secure my patient's airway. And then you should be having the second plan B ready. If my plan A fails, what should be my plan B? And you should be knowing that for plan B, the sufficient equipment should be handily available in your operation theaters. This is all the part of the planning, right, which you do pre-operatively. Now we'll discuss these things in these headings. Now, what are the tools of the airway assessment, right? That is there. It starts from focused airway history. Like we do PAC in all our patients, our main focus will always remain that history of comorbid illnesses. Our main focus is history of any past surgical history, right? But the focused airway history is very, very important in sitting in a PAC clinic, other than your medical and surgical histories. We'll be discussing what all with respect to the airway, we should be asking history from the patient. After history, there should be a general physical examination with regards to the airway and a focused airway examination. Airway imaging is coming into existence since the advent of ultrasound, right? Ultrasound has an important role in assessment of the airway, and this will be discussed in later half of my talk today. And then preoperative endoscopic airway assessments. So this is a comprehensive clinico-radiological airway assessment, which we are going to discuss in coming 40 minutes. Now, regards to history, right, which I was mentioning, you should always be asking, if you are asking about previous anesthetic exposure, the history, you should be asking whether the previous exposure of the surgery has a patient has encountered any incidence of difficult airway, right? That if the sometimes the anesthesiologist or the surgeon tells, and the patient has records also available in their packets, that the previous airway, so in the surgery, the airway was difficult. So it gives you an idea, right, what you are dealing with, right? Regarding systemic illnesses, specifically if your patient is a long-standing diabetic patient, right? If your patient is a long-standing diabetic patient, right, I should be telling you that in long-standing diabetes, there is a non-enzymatic glycosylation of the collagen. So what happens most of the time is that in these particular scenarios, there'll be limited neck mobility, right? Limited neck mobility leading to difficult intubations, right? That is there. So neck movement, assessment of the neck movement is very, very important, right? If your patient is a long-standing diabetic patient coming to you for some surgery. Specifically, if your patient is a case of rheumatoid arthritis or ankylosing spondylitis, immediately you should be knowing that these have airway concerns as well, other than other systemic concerns. Now, what are the airway concerns in rheumatoid patients? There is an immobility or hypermobility of cervical spine, temporomandibular joint, as well as larynx. Everything making both mag and mask ventilation as well as intubation difficult, right? If your patient is a case of ankylosing spondylitis, there is a fusion and rigidity of temporomandibular joint and the cervical spine. So atlantoaxial subluxation, almost 1/4 of your patients, right? The data says, the literature says that they may have an associated atlantoaxial subluxation. There is a risk of fracture of the lower cervical spine if you forcefully extend the neck of the patient. So you have to deal with the neck of the patient with a grace. If it's an ankylosing spondylitis, you don't have to hyperextend for any kind of an airway manipulation. You don't have to hyperextend the neck of the patient who is a case of ankylosing spondylitis. That is there. In cases of TM joint disorders, there may be arthritis, there may be synovitis in your patient. There is a decreased or a limited inter-incisor distance. So mouth opening is limited. So you should be knowing that most of the time, yeah, we'll be discussing this in detail as well, how to assess this set of patient, right? That in this set of patient, TM joint disorder, you should be knowing you hardly have an oral excess in your patient. So you have something below the neck, below the oral cavity, or you have some excess above the oral cavity, that is the nose. So nasal, retromolar intubation, awake airway management, they are the keys in managing any TM joint ankylosis patient, right? Now, this subset of patients are very, very common coming to us in our PAC clinics. Those patients who have cardiopulmonary involvements, right? That is there. Your patient may have a history of COPD or bronchial asthma, right? So airway manipulation of these patients, you can subject them to increased risk of bronchospasms. So proper airway assessment and management preoperatively can decrease the incidence of these complications. Obesity and advanced pregnancy, you have a decreased FRC, right? That is particularly there. So these have anatomo-physiological, concerns in these obese subset of patients. Obesity we'll also discuss in detail in the talk. Now, coming on to the clinical examination of the airway, this is very, very important. All our postgraduates should be knowing, right, how to examine the patient's airway. Whatever case given to you, be it a long case in your exams or a short case in your exams, right, you should be very, very well versed that in these long cases and short cases, that airway examination, your examiner is wanting you to tell properly, right? Sometimes examiners are fond of taking you to the patients and say, how have you assessed this patient's airway? Just show me a few of the important parameters. How have you assessed? So my main talk will be focusing on how to clinically, examine the patient's airway. The most important something is you have been listening to this since your first year in post-graduation, that Benumof's 11 parameter for airway assessment. So you should be knowing that what are the parameters and what are the interpretation of these parameters. This is also equally important. So Benumof's 11 parameters include intra-incisor gap. If it is less than 3 centimeters, it suggests difficult intubation. If your patient is having buck teeth, means a prominent overbite maxillary teeth, right? Length of upper incisors is important if it is more than 1.5 centimeters. That is there. Then other is a mandibular protrusion tests you have to perform. Malampati class, we all know, grade 3 and grade 4, that corresponds to difficult intubation. You also have to check the palatal configuration. That should not be a high-arched or a narrow palate, right? That either of the things are important. Thyromental distance, we'll be discussing in detail. Compliance of the mandibular space. This mandibular space, this has to be, this should not be stiff. This should be very soft. You know, if it is stiff, inturated, it means there is some kind of a mass occupying lesion in the submandibular space, making your airway difficult. Length of the neck, any short neck, any thick neck, you know, and range of movement of the neck, if it is not extension and flexion is not appropriate. So 3 parameters in the neck for all my postgraduates: length of the neck, thickness of the neck, and neck range of motion, right? Regarding the neck, three parameters are very, very important, right? That you have to, you know, be looking into it. After that, coming on to the mouth opening, right? Coming on to the mouth opening, or what we were discussing, that is the interincisor gap. The adequacy of mouth opening, that is the interincisor gap, how to measure it, right? Most of the time, we don't have a scale to measure the gap between the 2 central incisors, but you can use the fingers of the patient. Important is that the fingers should be of the patient, not of the anesthesiologist sitting in the PhD clinic, right? That is there because it is the patient's demography which we are comparing with the patient's, you know, airway. And that is there. So factors that interferes with the mouth opening, they include masseter muscle spasms, TM joint dysfunctions, progressive systemic sclerosis, and submucosal fibrosis to complete the list. That is there. You can see in the picture below that how this 3-finger test is being done, right? Patient is asked to open the mouth completely and then asked to put his 3 fingers between the 2 central incisors, right? In the oral cavity, important is the dentition. You should be making a note of missing, loose, or damaged teeth, or if at all patient is using any kind of an artificial denture. These all things also have a medico-legal importance, right? That is particularly there. If your patient is having a loose teeth or your patient is having an artificial denture, right? You should always and always be notifying it in your anesthesia operation theater notes in a pre-operative assessment. Yes, patient already had a missed teeth, because otherwise your patients or the attendants can, you know, and medico-legally sue you that and the teeth has been, you know, because of your procedures, you know, and the teeth has been damaged, which was healthy earlier, right? That is there. Dentures are of 2 types. You should be asking in the history of the patient when you visit the patient in a PSC clinic, that is it a fixed denture or a removable denture, right? And depending on the different practices, right? Some people prefer to remove the dentures and can deal with the edentulous patients. Some patients want that if it's a removable denture also, they would like to use the removable denture during the bag and mask ventilation. And once it is over, then during intubation, they would like to take it off or can be using it. It all depends upon the individual personal practices, right? That is there. And the fixed denture, certainly you can't be doing anything about it. So that is there. So having a history of denture is very, very important, right? That is particularly there. Regarding tongue, right? The size of the tongue is very important because sometimes the tongue is too large, right, to fit into the mandibular space, making the visualization of the glottic structures difficult. So you have to assess because this is the tongue is the hero when we'll be discussing, you know, in that modified Malampati classification grading, which I'm sure you have been, you know, doing it day in and out since your first graduate post-graduation days, right? Even in internship, when you come for this thing, anesthesia postings, that we tend to tell you about MMP classification. So I'm not going into the details that what is class 1, 2, 3, 4. I'm sure all postgraduates are well versed with all those nomenclatures, right? That is there. But what I want to emphasize here is that MP grading in both the supine and sitting positions have shown similar sensitivity and specificity. So assessment of both may add some value to your as a predictor for difficult, you know, airway. And that is there. There's a lot of buzz in last decade, I must say, that because what are we doing, my dear young friends, that we are intubating our patients mostly on the OT table when the patient is in supine position, right? And we are in a practice of doing this MMP grading in a PSC clinic or anywhere outside the preoperative room when the patient is in sitting position. So there are much of a literature which is available now, which says there is kind of a discrepancy at times when you assess the MMP grading in a sitting position and when you assess the MMP grading in the same patient in the supine position. So most of the recent literature have come up with the fact that if you have some kind of a suspicion in your mind regarding the patient's airway, do an assessment of the MMP classification, both in the sitting as well as supine position of the patient, right, to be more accurate. Right, that is there. So this is an important point which I want to emphasize, and this is the supporting large volume literature which I have come across, which says that yes, modified Mallampati classification performed in the supine position is possibly superior to that performed in the sitting position for predicting difficult intubation in adults. Right, that is particularly there. So some studies have found that the supine seems to be a better, have a correlation with the difficult airway or difficult intubations. Right, that is particularly there. There is a literature which is because the classical teaching which has been done since years, right, and that is there, that you have to assess the MMP class grading of any patient and ask the patient not to phonate. This is a classical teaching. Again, the high volume literature is coming up which says that even with the phonation, yeah, if your patient is phonating, right, that may also give an accurate assessment, a near accurate assessment of your difficult intubation with regards to Cormack-Lehane testing, right, that is there. But none of the literature commonly says that yes, with phonation is better or without phonation is better, because this every investigator has come up with different results. You can go with any of that, with phonation, without phonation, but earlier it was strictly without phonation in the previous years. That is there. So what we have to do, how to do a correct modified Mallampati assessment. We ask the patient to open the mouth and protrude the tongue maximally. This is important, right? The second thing, protrude, we should not be assessing it half-heartedly, right? It is not like that this is our regular job. We have been seeing 50 patients in our PSC clinic one day. So it's like MMP is something we are doing routinely. So it's just a formality. We just tell the patient, open the mouth. We just peep in for 2 seconds. We just look for 2 seconds and jot down the findings. It should not be like that. Proper instruction should be given to your patient if you're doing MMP, in any OPD settings. An important thing is ask the patient to protrude the tongue maximally, right? To all my postgraduates who can see this picture on the front of the screens, the incorrect part is that there is no complete tongue protrusion, right? That is there. And you can see those who are attentive till now, they can write it in the chat box. What is the MMP classification in this particular patient, right? I'll just give you 2 seconds. If anybody can write in the chat box, what is the MMP class in this particular, in this particular picture to my postgraduates, right? That is particularly there. So I'm very happy. Dr. Rahul has mentioned as MMP3. Right, Dr. Rahul, there's another, there is another picture for you on the screen. Right, it has become MMP2. Right, excellent, excellent. Very happy. I'm very happy with the postgraduates who are, very, very attentive to the talk. Yes, the first one was 3, and the second picture shows 2. So, what is the actual MMP grid classification of this particular patient? Right, what is the actual MMP classification of this particular patient? It's MMP2. Excellent. Once again, right, that is there. So you see how the difference has been made if the instruction is not properly given. MMP3 comes under difficult airway, whereas MMP2 is not classified under a difficult airway. So entire thing changes. Your entire management, your entire planning changes if you don't give a proper, instruction to your patient that what patient has to do. Excellent. I'm very, very happy. Right, that is there. Then coming on to another important parameter, that is thyromental distance, right? That is there, thyromental or the Patel's this thing test, which has been said, right? That is there. We all know TMD more than 6 centimeter predicts easy intubation. But again, my focus will be how to perform this test correctly, right? So it is from the tip of the thyroid cartilage to the tip of the chin. This is important. It is the tip of the thyroid cartilage. This is the tip of the chin. This is my tip of the thyroid cartilage. Adam's apple, more prominent in the males, right? Important thing which you can see in this particular picture on the screen is that a proper extension is required, right? A proper extension while you are assessing a thyromental distance, right? That is there. Then only you can have a correct measurement or a correct assessment of TMD, right? That is particularly there. right? So thyromental distance, right? But there are again a lot of talks about it, right? Again, my postgraduates can see that thyromental distance, if measured in a neutral position, it's underestimated, right? That is particularly there on the front of the screens. You can very well say and see in this particular lady, it's somewhere around 5 centimeters, right? So 5 centimeters, is it easy intubation or is it going to be a difficult intubation? Again, quickly in the chat box, easy or difficult, right? If this kind of a picture you see, this kind of a thing, excellent, excellent. Once again, this is important, right? They say it's a difficult kind of a thing, which is there. Now, see another picture, which is coming onto your screen, right? That is their TMD measured in extended center. What is the actual TMD in this patient? Actual TMD in this patient is around 8 centimeters, right? That is particularly there in 8 centimeters is a well good TMD, which doesn't qualify the criteria of difficult intubation. So again, right method of doing the airway assessment is very, very important if you really want to predict it, right? So that is there. Again, important something to all my postgraduates who are listening to me today, right? If in your exams you are having a case of thyroid, right? A good thyroid swelling, right? This is their colloid goiter, right? That is there. So while doing the airway assessment, you have to be very, very careful. You know, 1 or 2 of my residents only I have seen that they get nervous during the exam, and they say, when they were mentioning about 11 parameters of Benumov, they say my patient's TMD is 5 centimeters or 6 centimeters. Then examiner clearly asked, beta, just tell me that how have you measured thyromental distance in this particular patient? And then there was a silence for a while, and then it was like that, oh, I'm very sorry, sir. It's like it was a routine, but I didn't measure it, right? So if it's a big goiter swelling, you can make out, you can't be making out what is your, where is your thyroid notch, right? From which you have to measure the distance. So don't lose your nerves in your exams, right? This is there. Every point is not accessible in all the patients. This is very, very important, which message I want to give, that it doesn't mean that you have to think on the basis of 11 Benumov point, but in some points, if you're not able to assess it, you can easily mention your examiner that cannot assess this parameter. So this is how you have to present, right? Coming on to your mandibular protrusion test or the upper lip bite test, this also you have been doing it in your practice, right? Class 1, 2, 3. I'm not going into the details of that what is 1, 2, and 3, right? For all our postgraduates, I want to introduce to you one more terminology, that is upper lip catch test. If your patient is an edentulous patient, certainly he doesn't have a teeth, right, to bite the upper lip. So in this particular if you perform this test, it is called as upper lip catch test, right? That is there. Instead of that, only there is a difference in the terminology, right? Upper lip catch test. Temporomandibular joint subluxations. Again, you have to, joint mobility is assessed by asking. This is, one of the questions in the chat box, how to assess a patient with TM joint ankylosis or something like that, right? So mobility, how to assess mobility of TM joint? It is assessed by asking, the patient to open their mouth fully and then asking them to place their lower incisors as far forward relative to their upper incisors as possible. That is there. I again repeat the thing. It is by asking the patient to open their, mouth fully and then asking them to place their lower incisors as far forward relative to their upper incisors as possible. What is class A, B, and C in this? How to grade it? Class A means lower incisors cannot be protruded anterior to the upper incisors. Lower incisors can be brought edge to edge with the upper incisors. It's class B. And class C says lower incisors cannot be brought edge to edge with the upper incisors. So this is how you assess a patient with TM joint involvement, right? That is particularly there. Now, what are the evaluations of different? We have different airway parameters, right? Which ones are more sensitive? Which ones are more specific? So there is a lot of work being done worldwide, right? No consensus has been reached, unfortunately, that yes, this test per se has a better value, or this every research has a different something. But as a postgraduates, you should be knowing how to perform them properly and what are the different subsets you can combine to reach the better predictive values. So this is yet another study which says that MMP is more accurate, right, is there, though MMP is fading its charm in the recent times. This is important, that is sternomental distance. We have been focusing more on thyromental distance, right? And that is there. But most of the recent literature clearly says that sternomental distance is more of a sensitive parameter as compared to, thyromental distance. You should be knowing the value. What is the cutoff value for SMD? That is 12.5 centimeters. That is there. I again repeat, 12.5 centimeters. If it is less than that, it is shown to have a better sensitivity and specificity as compared to your thyromental distance, your upper lip things, your Malampati classification, right? And it correlates more with your CL3 and CL4 grading. Again, important is the landmarks. Upper border of the manubrium to the tip of the mandible. Tip of the mandible is the same. Now the lower margin is the upper border of the manubrium sterni. Again, neck in the extension, right? Again, neck in the extension. So that is particularly there. So that is, again, you have to see. Hyomental distance, again, as the name suggests, distance between the mentum and the hyoid bone. You grade as per the HMD into 3 grades, grade 1, 2, and 3. 1 says more than 6 centimeters, 2 is 4 to 6, and 3 is less than 4 centimeters. Grade 3 hyomental distance is usually associated with impossible laryngoscopy and intubation. So it should, you should have the signals in your mind that if it is grade 3, right? This is something new in the armamentarium of the assessment tests. That is thyromental height. I have seen many of the examiners are also fond of these days asking that how to measure thyromental height. Right? Because thyromental distance is an age-old story, which we are still doing it. But there are many literature recent in the last 5 years which has come up and says that TMH is more sensitive a parameter as compared to TMD. So how to measure TMH? You can very well see in the diagram, right? It is a measure of the vertical height from the anterior border of the thyroid cartilage and the anterior border of the mentum. It's a vertical height. I again emphasize, from the anterior border of thyroid cartilage to the anterior border of the mentum. So cutoff value of 50 millimeters allows optimal sensitivity and specificity, which correlates well with your difficult airway or difficult intubations. But again, large group studies are needed to validate it. But literature is evolving, and much of the literature is now available on TMH, which says that it has a very high sensitivity and specificity. This is again a study from our own IJA that is there, and from our Indian population. On the Indian population, we at Maulana Azad Medical College, New Delhi, myself only conducted a study with my group comparing TMH and TMD, right? It's again accepted for publication, and this is there again, the same findings. Very high sensitivity, specificity, almost more than 90% in our study also, and in their study also when we compare with TMD. Right? Now coming on to the neck part, clinical, to complete the clinical assessment thing, neck part. What 3 things I have told you, young friends, regarding the neck? Neck length, neck circumference, and neck range of movement. These 3 things are very, very important, right? That is there. Out of all, neck circumference and neck range of movement are the 2 important predictors of difficult airway, right? That is there. So what is Delican sign? Delican sign, as the picture clearly says, that you have to put 1 index finger of each hand, one on the chin and other index finger of the other hand on the inferior occipital prominence, right there. And patient is asked to fully extend the neck without moving the shoulder. Believe me, correct technique, again, very, very important. Should not be asking to move the shoulder, only extension of the neck. If the finger under the chin seems to be higher, there will be no difficulty with intubation. If the finger under the chin seems to be at the same level or lower than the other finger, increased difficulty is predicted. So this is something important, Delican sign regards to neck range of movement. So you should be well knowing it, that how to go about it. That is there. Again, important parameter, neck circumference to TMD ratio. This becomes even more important when we're discussing obese patients. So this is a very, very important parameter, the ratio, neck circumference by TMD. Any ratio of more than 5 is proposed as a better predictor as compared to so far whatever predictors we have discussed, right? Specifically in obese patients, right? That is there. Neck circumference by TMD ratio more than 5. Now, how to measure the neck circumference? Again, very, very important. Specifically, if you're dealing with the difficult airways in pregnancy, the obesity, the neck circumference, I again re-emphasize, it becomes very, very important parameter. So how to measure it, right? Again, look at the picture. Neck circumference measured at the base of the neck. Is it correct? Incorrect? Neck circumference. This is my own resident who on whom we have shot with his permission. Right, that is there. So is it correct? Incorrect? Yes, it's already written that it's an incorrect way, that it should not be measured at the base of the neck, right? It should never be measured at the base of the neck, right? So where to measure it then? If you're measuring the neck circumference, this is the correct way, right? And measured at the level of the thyroid cartilage, that the prominent part, the Adam's apple, the thyroid cartilage, the thyroid notch, the prominent part, that at that particular point, you have to measure that particular this thing. You can see very well in the measuring tape, the difference is there. If you measure it incorrectly, it's again, it can give you a wrong impression, right? So how to measure? So my focus in today's talk is always at all the parameters, that all postgraduates should be knowing how to correctly perform these tests, right, of the airway assessment, right? This is just this thing, head positioning during bag and mask ventilation, right? This is there. If you're placing the head in a neutral position while doing a bag and mask ventilation, what is happening, my friends, here? That the tongue is the culprit once again. It is blocking the airway. You can very well see that it's completely blocking the airway. Now see the difference. If the extension, the head position proper has been made, airways open up, the passage is all clear, whatever gases you are giving through bag and mask ventilation, specifically your oxygen, right, it's reaching the trachea very nicely, right? A word about airway assessment in our long-standing diabetic patients, because diabetes is rampantly increasing throughout our nation, right? That is particularly there. So with regards to diabetes, I really want to say, I tell you two signs to my postgraduates. What is this prayer sign and what is this palm print sign, right? That is there. With regards to prayer sign, it's the inability to approximate the palmar surface of both the hands. Picture clearly speaks everything, right? That is there. This patient is not able to approximate the two palmar surfaces, right? So long-standing diabetes, it is very common. And what does it suggest? It is suggestive of cervical spine immobility and thus difficult endotracheal intubation. So prayer sign, very easy to get it done in your patients. So most of the long-standing diabetes, you can be doing it, right? That is particularly there. Now, what is this palm print sign? Palm print sign, the patient's fingers and palms are painted, painted with ink and then pressed firmly against a white paper, right? It is also a predictor of difficult intubation. You can very well, see it in the picture, grade 0, 1, 2, 3, right? Particularly there, right? What all you can see, again, it is like, if it's like 3 and 4, it clearly predicts difficult intubation. Right, that is very clearly, being seen. There are various scores. I'm not going into the details of that, right? You're not much supposed to know it also. If you know it, it's very good. Wilson score, right? That is there, or Al-Ganzouri index, right? These all you can be reading it from your textbooks also. It's given in all the textbooks. But yes, two important combined scoring system, which is very easy to do and can be easily done in our settings, right? Number one is SARI, that is Simplified Airway Risk Index, which includes Malampati, neck movements, ability to prognathe, mouth opening, thyromental distance, weight of the patient, and history of difficult intubation in the past. So 0, 1, and 2. On the scale of 0, 1, and 2, you score these, these 7 parameters. And then if the score is more than equal to 4, it indicates difficult direct laryngoscopy and difficult intubation. So this SARI you should be knowing. I repeat once again, what are the 7 parameters? Malampati, neck movement, ability to prognathe, mouth opening, TMD, weight, and history of difficult intubation. So these all are, SARI indexes, right? That is particularly there. Now, another important thing, very easy to do and very, closely, this can be correlated with the difficult airway, right? And this is particularly there, right? So what is this 3-finger test, right? 1-finger test to assess the TMJ function, right? That's particularly there. 2-finger test to assess the mouth opening, 3-finger test to assess the mandibular space, the compliance of the mandibular space, right? That is particularly there, or the length of the mandibular space. So this is the 3-finger rule of 1, 2, 3. This you guys can be easily doing in all your patients without taking much time. That is there. Now, this was the clinical assessment part. To touch upon the role of ultrasound for airway evaluation, that is there. So focus for airway. What are the applications where all you can use in pre-anesthetic evaluation for assessing difficult airway? What important things you have to notice? Tongue thickness. Again, the tongue is the culprit, as I said in the beginning. Mean distance from the skin to epiglottis at the level of thyroid membrane. pretracheal soft tissue thickness at the level of the vocal cords, right? The levels are important. At what we have done in a clinical assessment, that at what level you have to measure, similar using the ultrasound, this is important, that at what level you have to measure, right? So this has become even important, right? That is particularly there. So hyomental distance, right? Ratio, identification of the cricothyroid membrane for FONA. So these all anesthetic evaluations you can do using your ultrasound. Regarding anesthetic planning, specifically, you can estimate the size of the pediatric endotracheal tube. That is particularly there. Pre-induction, you can also assess the gastric volume and the fasting status of the patient using an ultrasound. Intraoperatively, assessment of conformation of the endotracheal tube, both in adult and children, right, can be done. Recurrent laryngeal nerve integrity and vocal cord mobility at higher centers, people are doing it after the thyroid surgeries, complete thyroid resections, right? So these are the various applications of ultrasound with regards to airway. For our postgraduates, I'll just be touching the basic common things which you can see and how to locate on an ultrasound. That is particularly there. As I re-emphasize, tongue is the most important culprit. So tongue thickness measurement is important. So you can do vertically place your probe. You can see the probe position, right, in this particular picture, right, that is there. And you can see on the vertical, if you place the probe. So from the skin, you can see the tongue tip, you can see the tongue base, right, and ultimately you can measure the distance from the skin to ultimately the lower side, and this particular thing is 56 millimeters, clearly written on this particular thing. So tongue thickness measurement is important, right, which you can do by placing the probe. Important thing is where to place the probe and how to place the probe, whether it is sagittal, whether it is transverse, right, that is particularly there, right. Skin to epiglottis median distance, if you have to measure, you have to put the probe transversely, right, just above the thyroid notch, right, that is particularly there. And then you can be easily measuring the distance between the two. And that is there. This is important. Many of the examiners are fond of asking, if you have an ultrasound in your centers, that what is double track sign? Double track sign is for esophageal intubation. If your endotracheal tube has gone into esophagus instead of the trachea, right? I want to have your focus on A, B, C, and D, right? A shows how to place the ultrasound transducer, right? That is just above the suprasternal notch. And is it transverse or a sagittal? Yes, it's a transverse, just above the suprasternal notch. If you have to find out whether your tube is, whether it's in the trachea or the esophagus. So, and diagram B, which clearly says that the image of the normal trachea, this is how a normal trachea looks like, along with the thyroid gland. You can see the thyroid gland, TAG marks the thyroid gland, right? Both the sides, overlapping in the trachea, you can very well see in this particular diagram, right? And C picture says that, the tube is in the trachea. You can very well see tube is in the trachea, right? That is particularly there. And in the D, what are you observing? You are observing that your air mucosa interface, with the arrow marks. You can see a small arrow marks, right? That is there. That is your air mucosa interface, right? If your air mucosa interface is only one, the tube is in trachea. As in diagram D, you can see there are two, just above the posterior, you can see the two arrows, right? Which are the air mucosa interfaces. So you have two air mucosa interfaces. It means the tube is in esophagus and posterior shadowing is observed. You can very well see the posterior shadowing also in diagram D, which say this is what is called as a double track sign, right, for esophageal intubation, right? That is particularly there, right? So you can very well see that. Now coming on to the next important something after esophageal intubation through ultrasound, right? That is the confirming position of the pediatric cuffed endotracheal tube, right? As I have mentioned earlier, right? In pediatrics, you can be using this. You should be knowing something called as TRUST, tracheal rapid ultrasound saline test, right? Tracheal rapid ultrasound saline test, in which you inflate the cuff of, on the cuff of the endotracheal tube with the saline instead of air, right? Because again, a very beautiful, this thing interface is developed if you fill it with the cuff. So my main focus, which I want to do here in the diagram C, right? ATT tube is 3 centimeters above the carina. The saline inflated cuff allows the visualization of tissues deep to the cuff. That is important. You can see the star marks, So, and the star marks, it is basically, you can see the tissues which are deeper to the cuff, right? That is particularly there. That is the advantage of putting the saline in this particular thing. Now, this is mainly for the FONA, right? Identification of the cricothyroid membrane, right? That is particularly there. How to identify the cricothyroid membrane, how to identify the trachea and the tracheal rings in this particular plane, right? Your all focus should be on A. Diagram A, that is on the diagram A on the left, you can see transverse probe, the position of the probe, transverse ultrasound image of the trachea showing the cricoid ring and the trachea. C is a cricoid ring, this is how cricoid ring looks like, and T is the trachea, this is how trachea looks like, right? That is there. Now your focus should be on diagram B in the center, right? That is there. The position of the ultrasound transducer, the probe is changed, right? It has become sagittal now of tracheal showing the cricoid ring, right? The cricothyroid membrane and the thyroid cartilage. TC is a thyroid cartilage. CTM is a cricothyroid membrane, right? So if you make it, sagittal, right? These cricothyroid membrane is very easily being seen as a white listening structure. And this is what is your FONA thing, in an emergency, you can be doing FONA after visualizing this cricothyroid membrane. And last focus should be on the diagram C. Again, the probe is a sagittal probe, right? Showing you can see the cricoid ring. And the main thing which you're seeing here is tracheal rings also, right? Tracheal rings as well in the trachea. TR is the tracheal ring. So these are the beautiful diagrams being shot in my own, operation theaters, right? That is there. So again, position of the probe or this thing is important. Right. Again, various literature. I'm not going to the details, the sensitivity and specificity, right? That is particularly there. So what are the ultrasound predictors? This table I want you to learn by heart, all postgraduates, right? If you know ultrasound, if you have been asked about ultrasound in your exams, so what are the predictors of difficult intubation on ultrasound, right? That is there. This may answer a few of the questions in the chat box also, right? That is there. Tongue thickness, more than 6.1 centimeters. Tongue thickness to thyromental distance ratio more than 0.87, mean skin to epiglottis distance at the level of thyrohyoid membrane. I repeat, mean skin to epiglottis distance at the level of thyrohyoid membrane less than 2.54 centimeters. Hyomental distance ratio from neutral to neck extension less than 1.25. These are the predictors. Just to touch upon predictors of post-extubation stridor in pediatric patients, it is an alternate to cough leak test. That is their air column width less than 0.8 millimeters is an important predictor to predict post-extubation stridor, right? That is there. But application of ultrasound in airway assessment is a subject of ongoing research, right? Is a subject of ongoing research. Many things are evolving, right? That is there. To touch upon special scenarios like pediatrics and obesity in last 2 or 3 slides, right? That is there. Traditional airway assessment generally is not possible because we all know that the kid will not cooperate with us. Smaller kids will not cooperate with us. So we should be more relying on the history and general physical examination, right, of this this thing. On the basis of history and general physical examination, we should be knowing it. Specifically infants, right? And all infants, right? They should be considered as anticipated difficult airway. Right, that is particularly there. It's a blanket statement, right? That is particularly there with regards to history of snoring if the kid is giving, feeding difficulties if the kid is giving, right? Recent URI, CROUP, LRTI, right? Any history of in the past of difficult airway, right? This is all history which is important in pediatric patients. Whereas while examining head, neck, and cervical spine, because intraoral examination you'll not be able to do, child will not cooperate. Right? What examination you can be doing is you can be seeing whether there's a micrognathia, retrognathia, microtia, facial dysmorphisms, or these things you can be seeing the shape of the mandible, the size of the mandible, any syndromes, right? I have seen many of the examiners are very fond of asking what all syndromes are associated with difficult airway. So you should have list ready with you, right? That is particularly there. Okay, what all syndromes? Pierre-Robin syndrome, right? Yes, Pierre-Robin sequence these days it is being called as Pritchard-Collins syndrome, hemifacial microsomias, golden heart syndrome, and Klippel-Field syndrome to complete the list, right? So every syndrome has a difficult predictors for difficult intubation, right? That is there, right? So this is in pediatric patients, syndromal child. Yes, you can very well see few pictures, right? That is there. Pritchard-Collins syndrome. You can see Pierre-Robin sequence. You can see Down syndrome, hemifacial microsomia. So these all kids contribute to these all syndromes involves a difficult airway, right? That is particularly there. So again, pediatric airways. What are the predictors of difficult intubation? TMD in infants more than 1.5 centimeters or 1 finger breadth. Right, interincisor distance wherever possible you can do, but it's not always possible, as I already emphasized. MP grading may be insensitive in pediatric population, right? That is there. So you may not be having an accurate representation. Syndromic airway, you should be using guiding modalities like ultrasound, CT if there is an availability, preoperative flexible fiber optic endoscopy. There is a role in syndromic child, but again, these things are not available at most of the centers. So you should be knowing what all syndromes you should read up before taking up the case, that what airway involvement is anticipated and how can you troubleshoot it. Anthropometric parameters in the neonates, which predicts difficult airway, lower birth weight, less than 2.25 kgs, lower TMDs, less than 2.65, lower SMDs, frontal plane to chin distance is to weight ratio. These has the highest sensitivity to specificity. I repeat once again, frontal plane to chest distance is to weight ratio. That should be more than 0.395. That is there. So again, anthropometric correlations, multiple literature is there regarding your obstetric patients. Again, they are difficult airways, right? You should be knowing the reasons. You all know the reasons why they're difficult airways. I'm not going into the details, right? This is there. Age, weight, and Malampati class all are independent predictors of difficult airway or difficult intubation in obstetric patients. Assessment of Malampati in supine has a similar sensitivity and specificity to sitting in pregnant patients. MP grading increases during pregnancy and further with the onset of the labor. Patient in labor is more likely to have MP3 and MP4, right? It increases with the duration of the pregnancy. Increasing BMI correlates with increasing MP grading during the course of pregnancy. This is particularly there. Obesity during pregnancy is a major risk factor for airway adverse event, deadly combination, that is there. Just lastly, about the obese patients, yes, they are all anticipated difficult airway, difficult bag and mask, difficult laryngoscopy, even difficult supraglottic insertion, difficult fauna, and extubation is also difficult because at times post-extubation obstruction and there is a need for CPAP. So everything is difficult in obese patients. So a proper planning is very important when you are, this is discussing about obese patients, right? History and clinical examination with regards to airway in obesity, right? That is there. Stop bang of more than 3, right? History of snoring, history of OSA. This all makes the bag and mask and intubation difficult. Neck pad fat, increasing breast tissue, difficult laryngoscopy is there. High MP grading is a poor predictive value, both in, MP grading, both in pregnancy as well as obesity has a poor predictive value. So you should be relying on another important thing. So I have mentioned it in my earlier slides also, ratio of neck circumference to TMD, very, very sensitive and specific predictor, right? That is there of difficult intubation in obese patients, more than 5. Right, that is there. Neck circumference correlated for height also predicts OSA with a higher sensitivity and specificity. So neck circumference is measured at the level of thyroid cartilage. If you're just measuring neck circumference, more than 40 centimeters correlates to difficult intubation. But yes, even more sensitive is the ratio of neck circumference to TND. Right, that is there. Ultrasound can play an important role in obese patients, but still under evaluation, right? That is there. So I'm not going into the details of that, right? That's particularly there. A lot of literature is available, right? That is there. Sublingual ultrasound, it's out of purview of your this thing in obese patients. So airway imaging, not only the ultrasound, but X-ray, lateral X-ray, soft tissue, neck in sniffing position also tells you a lot of things about a difficult airway, right? Specifically in the obesity, right? If you don't have an ultrasound facility, then you can be asking lateral X-ray soft tissue neck in the sniffing position, right? That is particularly there. So points to ponder in obesity, right? That is there. It's a little controversial. I don't know what are the reasons, but yes, our Millers also say male sex consistently associated with higher risk of difficult intubation in obesity. No reasons not known right till now. I thought that it may be the female sex which is more correlated with this thing, but the book says something else. High MP grading correlates weakly with CL grading. This we have already mentioned. Obesity by itself is not a good predictor of high Malampati grading. Not every obese patient has a difficult airway. There are surprises that we have planned everything, but somehow it comes out to be very easy intubation at times. But yes, planning is important. If adequate ramping is done, right, you will never fail. But single parameter, if you have to select important predictor, I re-emphasize, it's either neck circumference by TMD ratio or neck circumference by height ratio. My favorite is neck circumference by TMD ratio, and ultrasound can be used for that. So with this, I come to an end of my talk. Right? These are my take homes. that modified Malampati grading may be carried out in sitting and supine position with a similar predictive value, right? If you are anticipating a difficult airway by different parameters, I advise you should check MMP both in supine and sitting position. Assessing both may add on to the value. This is what I've been emphasizing. Thyromental height and thyromental distance to neck circumference ratio are the newer indices with good predictive value for difficult airways, right? Tongue thickness, pre-epiglottic soft tissue thickness appears to be consistent ultrasound predictors for difficult airway, right? This may answer many of my chat box questions that if it is a clinical, you have to say what are the sensitive, most important good predictive value predictors? It's TMH or the TMD by NC ratio. If you're using an ultrasound, tongue thickness and pre-epiglottic soft tissue thickness, we have seen how to measure it in the pictures. Considerable scope remains to explore utility of the focus in the airway assessment, specifically in obese and pediatric anesthesia. It's a field of exploration, right? I once again bring my greetings from Maulana Azad Medical College, New Delhi, and wish to thank my other teammates, that is Dr. Arshi, Karthik, and Dr. Vijay, right, who have given me good inputs for making this presentation in front of you. Thank you.
Thank you, Dr. Amit Kohli, for the excellent presentation. Can we go to the questions in the chat box? There are a few questions in the chat box.
Yeah, sure, sir. Sure, sir. We can go it right away also or after the PG talk. I am there with you till end.
Yeah. Can we go it now?
Anyhow.
Yeah. So Dr. Farida has asked, how will we measure the neck movement using goniometer in order to report to the degree of movement?
Yeah, goniometer is an important tool which has been used in various research projects, the thesis also, right? You should be knowing how to measure, how to use this goniometer properly. This is there. And then second part you should be knowing is that using the goniometer, what are important predictors, right? I'll deal it with one by one. That sabse pehle, importantly, that how to use it, right? Various videos are there, doctor, available on the YouTube itself, that how to measure it. But yes, to re-emphasize that is there, that the neck should be there. You should have a support of one hand at the back, likewise, if you can very well see, then, one hand on the forehead, right? Then you'll ask, you'll put the goniometer on the side, then you'll be asking to, put your, ask the patient to move this higher up, and then you can be, another important point which I want to emphasize that where to keep, shoulder should be, again, the shoulder should not be up, right? Shoulder should be at the same level, right? Then you can be checking first the range of movement on both the sides before using. These are the prerequisites for using goniometer on both the sides, this and this. Then I told you that how to, this, and then applying. It's an acute angle, it's an acute angle that how should be applying this, one scale here, and then the angle in between the two scales. This is how. If you see the video, you will be able to see lot of videos are there in this thing. It's very difficult to explain it on this particular thing. No, very nice goniometer videos are there, and that you can be very well seeing it.
Okay. Now there is another question. Like the SARI and the El-Ghazouani scoring system, both are the same or different?
Yeah, they're the earlier it was called as that, but SARI is they're the same things. They're the same things.
So you can say that SARI instead of El-Ghazouani.
Yeah, very true.
It's a validated scoring system combining most of the clinical parameters.
Yes.
Thank you. And skin to epiglottis distance measurement, which probe will you use? Linear or?
Sorry, I didn't hear you.
The skin to epiglottis distance, which probe will you use?
It's actually a sagittal one. It's actually, I've shown it in the picture also. I've shown it in the
probe.
Acha, the probe. Okay, because I was not able to hear you that very time. Okay, the probe which you're using. So because there's some kind of a network disconnectivity. So this thing, because skin to epiglottis is very difficult to visualize the epiglottis at times with the ultrasound. So it's always better to use a curvilinear probe, so that you can see the deeper structures better with that particular thing. So this is.
And which is the best position to measure the skin to epiglottis distance, in the supine position or in the sniffing in the morning air position?
if you want to measure the skin to epiglottis distance, right, most of the recent literature says is a sniffing position, you get a better accurate assessment. You can do it in either, but to get a better accurate assessment, if your patient is supine, make a sniffing in the supine position and then put your ultrasound probe. That will give you a better correlation with your difficult airway.
And what is the measurement actually? It's 25 millimeters or 18 millimeters?
25 millimeters, I think I have mentioned it.
Yeah, you have mentioned it. But
Yeah,
because what I am asking specifically is that there are two different studies.
Exactly.
One by Dr. Pankaj Kundra et al. And other by Dr. Aruna Parameshwari, mentioning two different measurements.
Two difference. Yeah.
So anterior neck tissue at the level of hyoid bone, that's you have mentioned the cricothyroid membrane.
So the question is not clear.
Yeah, that question is not clear. From Dr. Sia some Akshaya, she can unmute and ask.
Or else my email ID is there. Any of your students want to interact with me, they can interact with me on my email. It's dramitkohli@yahoo.com. I again repeat, dramitkohli@yahoo.com.
Can you put that in the chat box?
Yeah, sure, I'll do it. I'll do it for your students.
And another question, best ultrasound measurement for difficult airway among these?
That was my concluding slide. I want one of my students to answer this. I'll be very happy if any of my students attending the class will write it in this thing, because that was the take-home message.
Yeah.
You should be giving some kind of a chocolate to the student who will write it, and I'll be the happiest if somebody write it. This is my email ID for all my students. And that is there. I have specifically rated it in the caps, but it's not in the caps, so that you will not, confuse between any of the alphabets, right? So that is particularly there. So I'm just waiting if anybody writes it in the chat box. Else, I'll just say for a predictor in the ultrasound, it's two things I've told you. That is, one is tongue thickness and other is pre-epiglottic soft tissue thickness. The two things. The best predictors on ultrasonograph for predicting difficult airway.
So what about the skin to epiglottis?
Yeah,
distance?
Dr. Aishwarya Pillai, Dr. Rajesh, you should be giving a chocolate to her.
Yeah. Okay. What about the skin to epiglottis distance?
Skin to epiglottis distance is also one of the very good predictors on ultrasound that is there. But what I again says is locating epiglottis at times is really difficult on ultrasound, specifically for those beginners. That is particularly there. Measuring tongue thickness is pretty easy, and soft tissue thickness is pretty easy on ultrasound, specifically for beginners. But yes, skin to epiglottis thickness is again a very good predictor for difficult intubation if you are very well versed with ultrasound, using ultrasound. And Rahul, this neck circumference by TMD is mainly for mainly the obese patients, is high sensitivity and specificity, right?
Yeah, the other questions I already answered. USG sitting or supine.
Yeah.
That we have already.
Yes. Most of the questions I tried, Dr. Rajesh, to cover up in between itself because I was continuously seeing the chat box.
Pre-epiglottis tissue distance for ultrasound.
What is that? What is the question?
Yeah, Sana Fadal.
Yeah, you can email me the question. Now my mail is in front of you all, right? I would love to interact with you all on email, right? That is there, and we can discuss even more than assessment, right? The management as well. Yeah.
So any student can unmute and ask the questions directly, and we also request. There are some senior faculties in the audience, like Professor U.S. Ravindra, who is really interested in airway. Professor U.S. Ravindra, sir, you can unmute and ask, give your comments. And here.
I think there may be some connectivity issue with him.
Yeah. I think you have
But Indra
answered
is
most.
not in India. That's why he is not able to speak. He is
Okay,
in Brunei.
okay,
He is in
okay.
Brunei.
Okay. Anyway,
Wait.
you have answered most of the questions.
Thank you very much, Dr. Rajesh.
It
Thank
was a
you.
wonderful presentation.
Thank you.
Yeah, that's from Dr. Lalit Kumar Raiga, not able to unmute.
Yes, sir.
That's
Can you hear
I
me?
think
Yeah,
Lalit sir is audible now. Lalit sir, you are audible now.
Yeah, yeah. Sir. Yes, sir. Sir, can we able to make a check laryngoscopy to identify whether we can able to feel difficulty during laryngoscopy and intubation?
Yes, most of the time, at least we don't have those gadgets available with us, or we do it doing a check laryngoscopy. But again, the thing is, like, for doing a check laryngoscopy in a awake patient, you need patient cooperation. So at times, what we do, I would like to hear from you also and the eminent people sitting to deal with the airway, that what we do these days is, when these difficult airway patients, we topically prepare the airway and then do a check laryngoscopy and then go ahead.
I am in clinical practice to doing this thing. If patient is able to cooperate with local topical spray,
yes,
I have to do check laryngoscopy, so I can able to
very true.
know whether I am able to
certainly
do laryngoscopy and able to intubate under general anesthesia.
Yes, sir. It's a very good practice. And one thing, sir, I want to add on into it is that for topicalization, I have also been using sprays for years. But now with the advent of and with the easy availability of this lignocaine lozenges, this is awesome. This thing that the dose is also reduced. Patient compliance is very good with this, and the oral topicalization for check laryngoscopy with these lozenges is excellent. Right, and along with that, if still you feel your patient is not very cooperative, dexmetomidine is a very good drug. Yes, sir.
There is a comment from Dr. Anil Kumar MR. That's we use the Dexmed loading dose to do checkoscopy.
Yeah, that's what I said, that the initial should be topicalization, but if you still feel like the patient cooperation is not that great to do a check laryngoscopy, dexmetomidine loading is a beautiful agent. We all have been using it, I'm sure, for these things without much of any side effects, and patient cooperation drastically improves. Right. So as Lalit sir has rightly said, that check laryngoscopy these days also we are using with lignocaine lozenges and dexmetomidine. These two are excellent agents for the same.
Yeah, definitely. Dr. Kohli, for the beginner, when we are giving topicalization, first we have to spray directly on the soft palate, and then later on we can able to go downward, so that spray will go directly to the epiglottis.
Certainly, sir. It's an important point for all postgraduates who are listening, which Lalit sir has said. Yes, step-by-step topicalization of the upper part first, and then going a little down. The patient cooperation will be better, And sir, you must have used these lozenges and this thing. So this thing, that topicalization of the soft palate and then going down, this all problem goes away.
I had used lollipops. Lozenges.
Yeah, lollipops. Yeah, lollipops or lozenges is just 10 minutes. It takes 10 minutes, and patient compliance is excellent.
Yeah. And the ENT surgeons is very fond of my ENT surgeon. When it was available, they were able to do the laryngoscopy easily.
Very true, sir. Very true.
To take biopsy also.
Certainly, sir.
Yeah. Okay. Thank you.
If there are no more questions, thank you, sir. Thank you, Lalit sir, for the comments.
Sir.
Yeah. If there is no more comments, we'll go to the next session, PG Corner. I invite Dr. Sheila Madam. She's the professor and HOD at Kottayam Medical College. Sheila Madam, please.
In fact, am I audible?
Yeah, Madam, you're audible.
Yeah. Okay, good evening to all. I must thank the ISA webinar coordinators for giving Kottayam Medical College postgraduates an opportunity to present the topic in this prestigious platform. So I invite the two postgraduates, Dr. Premjit, who will talk about Dexmeditomedine, and Dr. Meenu Krishnan, who will present Capnography. Both are third-year students. So can we go ahead?
Madam.
Okay. Dr. Premjit, can you start your presentation?
Respected teachers and dear friends, a very good evening to one and all. Today, I will be discussing on the topic on the drug Dexmeditomedine. Dexmeditomedine is a potent alpha-2 adrenergic receptor agonist. The alpha-2 adrenergic receptor agonists have sedative, anxiolytic, hypnotic, analgesic, and sympatholytic effects. One of the highest densities of alpha-2 receptors is located in the pontine locus coeruleus, an important nucleus mediating sympathetic nervous system function, vigilance, memory, analgesia, and arousal. The sedative effects produced by dexmedetomidine are largely due to inhibition of this nucleus. Its potential for use in anesthesia was recognized in patients who are treated with clonidine. A reduction of the mark of halothane was observed when it was used along with clonidine. About the history of dexmedetomidine, it is a more selective alpha-2 adrenergic receptor agonist with a selectivity ratio for alpha-2 receptor 1600/1. It was introduced in clinical practice in the United States in 1999 and approved by the FDA only as a short-term sedative for mechanically ventilated adult ICU patients for a period of less than 24 hours. Dexmedetomidine, coming to physicochemical characteristics of the drug. It is the S-enantiomer of medetomidine, a substance that has been used for sedation and analgesia in veterinary medicine for many years. And it shows a high ratio specificity for alpha-2 receptor compared to alpha-1 receptor. The selectivity ratio for, that is the alpha-2 by alpha-1 ratio for dexmedetomidine is 1600:1 compared to clonidine, which has got a selectivity ratio 220:1, thus making it a complete alpha-2 receptor agonist. The pKa value of dexmedetomidine is 7.1. It's an image showing the chemical structure of the drug. The chemical structure contains the imidazole ring. Dexmedetomidine belongs to imidazole subclass of alpha-2 receptor agonist similar to clonidine, and it is freely soluble in water, and it is available as a clear isotonic solution containing 100 microgram per ml of the drug. Before infusion, we have to reconstitute this solution, and it has to be diluted to a concentration of either 4 microgram per ml or 8 microgram per ml. We can reconstitute by adding either saline, 5% glucose, mannitol, or vinegar lactate solution. About the metabolism and pharmacokinetics of the drug. It should not be combined with several drugs like amphotericin B in liposomes, diazepam, phenytoin, gemtuzumab, irinotecan, or pantoprazole. And dexmedetomidine undergoes almost complete biotransformation with very little, almost complete biotransformation, which occur in liver, and very little drug is unchanged, and it is excreted in urine and feces. The biotransformation involved both direct glucuronidation as well as cytochrome P450 mediated metabolism. The major metabolic pathways of dexmedetomidine are direct N-glucuronidation to inactive metabolites, hydroxylation, and N-methylation. One of the important characteristics of this drug is that it is nearly 94% protein bound. Regarding cardiovascular effects of dexmedetomidine, the main cardiovascular effects are bradycardia, transient hypertension, and hypotension. Another peculiarity of this drug is that it can alter its own pharmacokinetics. When we administer the drug in large doses, there is marked vasoconstriction, which leads to transient hypertension, which probably reduces the drug's volume of distribution, and thereby it can alter its own pharmacokinetics. The observed hypertension may be avoided by decreasing the loading dose or by increasing the time of administration of loading dose. It follows non-linear pharmacokinetics. That is, when the drug is administered at low doses, the plasma concentration and the dose is directly proportional, and it follows a linear pattern. And when the drug is administered at higher concentration or higher drug doses, it lead to a small change in or small addition of drug dose can lead to a rapid increase in plasma concentration. So thereby it follows non-linear pharmacokinetics. In subjects with varying degrees of hepatic impairment like child class A, B, and C, clearance values for dexmedetomidine are lower than in healthy subjects. That is, the mean clearance value for patients with mild, moderate, and severe hepatic impairment are 74%, 64%, and 53% of those observed in normal healthy subjects. The pharmacokinetics of dexmedetomidine are not influenced by renal impairment up to a creatinine clearance of 30 ml per minute. Whereas in patients with severe renal disease, the sedative effects may be little more stronger due to a lower degree of plasma protein binding. Also, the pharmacokinetics of dexmedetomidine are not influenced by age. Elimination half-life of the drug is nearly 2 to 3 hours. Whereas the context sensitive half-life, it ranges from 4 minutes after a 10 minutes infusion to 250 minutes after an 8 hours infusion. Coming to pharmacology, the mechanism of action. It acts as a non-selective alpha-2 adrenergic agonist on membrane-bound G-protein coupled alpha-2 adrenoreceptors. The intracellular pathways include inhibition of adenylate cyclase and modulation of calcium and potassium ion channels. There are 3 different subtypes of alpha-2 adrenoreceptors, which include alpha-2A, alpha-2B, and alpha-2C. The alpha-2A adrenoreceptors are primarily distributed in the periphery, whereas alpha-2B and alpha-2C receptors are distributed in the brain and spinal cord. The presynaptic and postsynaptic alpha-2 receptors mediate different action. The postsynaptically located alpha-2 receptors in peripheral blood vessel will cause vasoconstriction, whereas the presynaptic alpha-2 adrenoreceptors will inhibit the release of norepinephrine, causing vasodilatation. That is, a postsynaptic and presynaptic alpha-2 adrenoreceptors are having opposite actions. The overall response to alpha-2 adrenoreceptor agonist is related to the stimulation of alpha-2 receptors located in the CNS and spinal cord. These receptors are involved in sympatholysis, sedation, and anti-nociceptive effects. Another advantage of this alpha-2 agonist is that their effects are readily reversible by several alpha-2 adrenergic receptor antagonists. For example, atipamezole. This is specific antagonist of the drug dexmedetomidine. Atipamezole is currently not approved for use in humans. It is a specific and selective alpha-2 receptor antagonist that rapidly and effectively reverses the sedative and cardiovascular effects of IV dexmedetomidine. The 3 alpha-2 receptor subtypes acts by controlling norepinephrine or epinephrine release from central or peripheral adult neurons. Among the 3 different types of alpha-2 receptors, alpha-2B receptors have been implicated in development of placental vascular system during the prenatal period. That is, alpha-2B receptors are involved in placental angiogenesis. Coming to the action of dexmedetomidine on different organ systems. About the actions on CNS, the most important action of dexmedetomidine on CNS is sedation. Alpha-2 agonists, they produce their sedative hypnotic effect by an action on alpha-2 receptors in the locus coeruleus, as we have discussed earlier. It produces a decrease in the activity of projections of the locus coeruleus to the ventrolateral preoptic nucleus. As a result of this, the GABAergic and galanin release in the tuberomammillary nucleus is increased. Both of these are inhibitory neurotransmitters, producing decrease in histamine release in the cortical and subcortical projections. The alpha-2 agonists inhibit ion conductance through L-type or P-type calcium channels, and they facilitate conductance through voltage-gated calcium-activated potassium channels. That is, mainly they cause inhibition of calcium channel and stimulation of potassium channels. Dexmed induces sedation through different receptors than other IV drugs like propofol or benzodiazepine. This propofol and benzodiazepine, which exert their action through GABA system. Whereas the sedative effect of dexmedetomidine acts through endogenous sleep promoting pathway, which mimic natural sleep and generating natural sleep pattern. The sleep pattern is of NREM type. The inhibition of locus coeruleus by dexmedetomidine releases the inhibition locus coeruleus has over the ventrolateral preoptic nucleus. That is, normally we can see here that there are three levels. One is the lowermost one is locus coeruleus, which has good projections to the higher level ventrolateral preoptic nucleus. And from there, the higher level is tuberomammillary nucleus. The first picture shows in an awake patient where normally the naturally locus coeruleus has got an inhibitory effect on VLPO. So the inhibitory neurotransmitter release from VLPO is prevented. So and thereby histamine release occur, which make the patient awake. Whereas in a patient who received dexmedetomidine, dexmedetomidine, as we have discussed earlier, inhibits locus coeruleus. So the inhibitory effect of locus coeruleus on ventrolateral preoptic nucleus is lost. So lead to activation of VLPO, which releases inhibitory neurotransmitters like GABA, galanin, which activate the tuberomammillary nucleus, and this produces the natural sleep pattern or the NREM sleep. So once again, dexmed causes inhibition of locus coeruleus, and thereby it releases the inhibition locus coeruleus has over ventrolateral preoptic nucleus. The VLPO subsequently releases GABA onto tuberomammillary nucleus, which is an inhibitory neurotransmitter, and inhibit the release of arousal promoting histamine from cortex and forebrain, thus producing loss of consciousness, and which induces natural sleep. Patients have been described as being very easy to wake up and having the ability to follow commands and cooperate while being tracheally intubated. Those patients who received dexmedetomidine. Also, undisturbed patients were noted to fall asleep momentarily. Both these characteristic features allows for daily wake-up tests to be done in a safe fashion using dexmedetomidine. This daily wake-up test, when used in ventilated ICU patients, are taken off all sedatives to assess their mental status and titrate sedation. So Dexmed enables conducting easy daily wake-up test, and thereby shortens the length of ventilator and ICU stay in those patients. The number of patients experiencing delirium in the ICU was found to be significantly lower when sedated with dexmedetomidine compared to other drugs like propofol, lorazepam, or midazolam. Although the precise mechanism by which dexmed preserve cognition is still unclear, there are data suggesting that the suppression of GABA, alpha-5 GABA type A receptor expression is involved in this maintenance of this causing this conscious sedation. That is, in simple terms, dexmed preserves cognition by suppression of alpha-5 GABA type A receptor expression. Another central nervous system action is producing analgesia. The analgesic effect of alpha-2 agonist is mediated through stimulation of alpha-2C and alpha-2A receptors in the dorsal horn. The drug directly suppresses pain transmission by reducing the release of pro-nociceptive transmitters, substance P and glutamate, and causing hyperpolarization of interneurons. Systemic use of dexmed has an opioid sparing effect during surgery and also in the post-operative period. This effect is advantageous in patients who are prone to post-operative apnea or hypoventilation, as with patients undergoing bariatric surgery. In the post-operative ICU setting, narcotic requirements were reduced by nearly 50% when patients are receiving a dexmedetomidine compared to a placebo. During general anesthesia, it reduces the minimum alveolar concentration of inhaled anesthetics. Another use of dexmedetomidine is it can be used as an adjuvant in central or peripheral neuraxial blocker. When administered as an adjuvant in caudal anesthesia, caudal epidural block, In children, it was found that the postoperative analgesia was prolonged. When the drug was administered as adjuvant to ropivacaine in vaginal nerve blocks, it was shown that the drug causes intensification and prolongation of the sensory block. This effect is likely elicited by prolonged hyperpolarization of the unmyelinated C fibers, which are sensory, and to a lesser extent, causing hyperpolarization of the motor A fibers. About the role of central nervous system protection, the prevalent idea is that dexmedetomidine reduces the intracerebral catecholamine outflow during injury. The neuroprotection may be attributed to modulation of pro-apoptotic and anti-apoptotic proteins. The reduction of the excitatory neurotransmitter by glutamate by dexmedetomidine during injury may explain some of these protective effects. Also, the drug has been used in neurosurgical procedures involving neurophysiologic monitoring. Cortical evoked potential, amplitude, and latencies were minimally affected when the patient is given dexmedetomidine intraoperatively. Another use of this drug is that it is found to be suitable as an anesthetic adjunct during seizure surgery, since the epileptiform activity of the seizure foci was no longer reduced by dexmedetomidine. Coming to effect on respiratory system. In spontaneously breathing patients, dexmedetomidine at concentration producing significant sedation was found to reduce minute ventilation, whereas it resulted in no change in arterial oxygenation, pH, or the slope of the CO2 ventilatory response curve. Also, the hypercarpic ventilatory response was found to be unaffected even when dexmedetomidine is given at large doses that produced unresponsiveness to vigorous stimulation. Dexmedetomidine also exhibited a hypercarbic arousal phenomenon, which has been described during normal sleep. That is, in a nutshell, it causes a reduction in minute ventilation, whereas most of the other parameters are unaffected. About the effects on cardiovascular system by dexmedetomidine, the most commonly reported hemodynamic adverse effects associated with the drug were hypotension, transient hypertension, and bradycardia. The initial increase in arterial blood pressure is probably due to vasoconstrictive effect of dexmedetomidine when stimulating peripheral alpha-2 adrenoreceptors. The incidence of hypotension and bradycardia may be related to the administration of the large IV loading dose. We can avoid this adverse effect by omitting the loading dose or not giving the loading dose more than 0.4 microgram per kg. Giving the loading dose over 20 minutes also minimizes the transient hypertension. In a small percentage of patients, profound bradycardia, that is less than 40 beats per minute, was observed and occasionally led to sinus arrest or pause. But generally, these episodes resolved spontaneously or were readily treated without adverse outcome by anticholinergics. No rebound effects have been found when discontinuing dexmedetomidine infusion, even after giving for more than 24 hours. By reducing the perioperative oxygen consumption and blunting the sympathetic response to surgery, dexmedetomidine also improves the cardiac outcome of the patient. About the uses of the drug dexmedetomidine. As a short-term sedative for adult intubated patients in the ICU, then procedural sedation, sedative agent during radiological or invasive procedures, then sedation for MRI scan. It can also be used as a pre-medication agent. It has a high bioavailability when administered nasally or buccally. This improves patient compliance and absorption in younger children. It is recommended that a dose of up to 3 to 4 microgram per kilogram 1 hour before surgery is safe and effective. Another important use is for intraoperative sedation for patients receiving local anesthesia or regional blocks. When compared to drugs like propofol, dexmedetomidine has slow onset but prolonged duration of action. Also, it can be used as a total anesthetic agent for TIVA when given at 10 times the normal sedation concentration range. It was observed that the cooperative status of the patient at a lighter sedation level was good, and it also has an analgesic effect with sparing of respiratory function. These properties makes the drug suitable as a hypnotic during surgical procedures like airway craniotomy, deep brain stimulation, surgery near speech areas, and awake carotid endarterectomy. It was observed that during these procedures, there were fewer fluctuations from the desired sedation level, and the hemodynamics were more stable compared to other drugs. A recent study showed that dexmedetomidine may be advantageous by improving the quality of emergence from general anesthesia by avoiding coughing, agitation, hypertension, tachycardia, and shivering. That is, it eliminates the cause of the incidence of emergence delirium after general anesthesia. Another important advantage is opioid sparing effects, which are advantageous in the performance of bariatric surgery in patients who are prone to postoperative respiratory depression. Dexmedetomidine is also useful in addiction treatment. It has been described for using rapid opioid detoxification, cocaine withdrawal, and iatrogenic induced benzodiazepine and opioid tolerance after prolonged sedation. One of the important effects of dexmedetomidine is it produces dry mouth due to decrease in salivation. This effect combined with the sparing effect on respiratory function is beneficial for facilitation of awake fiber optic intubation. That is, the effects like dry mouth and impaired respiratory function make it a suitable drug for awake FOB introduction. Dexmedetomidine decreases intraocular pressure and it decreases the shivering threshold. Another important use of dexmedetomidine is as a sedative agent in the ICU. It can be used for sedation in mechanically ventilated post-operative patients. Patients who receive dexmedetomidine had greater recall of the stay in the ICU and decrease the requirement for opioid. That is, more than 50% reduction in the opioid requirement were observed when dexmedetomidine is used as a sedative agent compared to other drugs like propofol or benzodiazepine. Hemodynamics during weaning were found to be more stable, which benefits patients with high risk for myocardial ischemia. For sedation in the ICU, a loading dose of 0.5 to 1 microgram per kg per kilogram have been used. Omitting the bolus dose or giving the lower dose has been associated with fewer episodes of severe bradycardia and other hemodynamic perturbations. For infusion, a dose of 0.1 to 1 microgram per kilogram per hour are generally needed to maintain adequate sedation. It also improved the patient's ability to communicate pain compared to other drugs like midazolam or propofol. The unique characteristic feature of dexmedetomidine, that is providing adequate sedation with minimal respiratory depression, make this drug selective alpha-2, make this drug very useful when weaning patients from mechanical ventilator. While the FDA approved use of dexmedetomidine infusion for 24 hours is less, that is, FDA approved the use of dexmedetomidine for a period of less than 24 hours. Multiple studies have shown that the safety of using this agent for longer period can be used even up to 30 days. That completes my topic. Thank you.
Thank you, Dr. Premjeet. You have presented it well. You are final year student now. Premjeet?
Yes, sir.
Yeah, very good. Yep. So open for discussion. Any questions or comments?
I think there were two questions in the chat box. One was regarding the dose of dexmedetomidine in caudal block. In Miller, it was mentioned that 1 mics per kg along with bupivacaine can be given for caudal block for pediatric patients.
And the second question is regarding the using labor analysis.
And because in the textbook, it is not mentioned regarding the use for pregnant patients, but studies have shown that cases for neurosurgical procedures, they have used dexmedetomidine without any adverse effects. But I have no experience in using dexmedetomidine in pregnant patients. I cannot comment on that.
Okay, madam. Thank you. So another question is, what is the additive dose for regional anesthesia in pediatric patients? Madam has mentioned the dose in caudal.
In pediatric patients only.
Yeah.
1 mics per kg.
Yes. And what about the dose in plexus block?
Tracheal plexus block. I think,
so
Premjit, have you used that in tracheal plexus block?
Yes, madam, 0.1 to 0.4 microgram per kilogram.
Very good. And another, not a comment, it's another, not a question, another comment is that we find it very useful agent for patients with the thyroid surgeries, just like a clonidine, when you use it, NIM tube, neural integrity monitoring tube, because we cannot use muscle laxants, and using alpha-2 agonists will reduce the MAC requirement and patient will stay comfortably on the tube. That's one comment. And Dr. Premjit, you have mentioned about some of the patients developing bradycardia. Severe bradycardia is the, can you predict the kind of patients who are likely to develop a bradycardia, like any depending on the QT interval or something? Patients with the prolonged QT interval or patients borderline elevated QT interval, are they more prone for developing bradycardia? Have you come across any literature?
Patients with the
because we generally won't give it to patients with prolonged QT interval, fearing severe bradycardia on loading dose. That's why, because I haven't come across any literature to support that. That's why I asked specifically.
Okay, sir.
And regarding the transnasal route, we use it routinely for pediatric patients, especially for ENT procedures and all. But it is yet to be approved FDA, isn't it? But there are a lot of, it's a lot of off-label use of dexmedetomidine for outside OT procedures and all, and there's a lot of literature evidence also.
Okay, sir.
Madam?
Yeah.
Can we go to the next question?
Yeah. I think Dr. Meenu Krishnan will present capnography.
Premjit, can you stop sharing? Any issues, Premjit?
Is the slide visible to all?
Yes.
Shall I start?
Yeah, sure.
Good afternoon, everyone. Today, my topic for presentation is capnography. So, capnography is the continuous, non-invasive measurement and graphical display of end-tidal carbon dioxide concentration versus time, which is known as the time capnography, or volume during a respiratory cycle, which is known as volume capnography. Coming to the concept of carbon dioxide transport and monitoring, we usually inhale oxygen, which is then transported via the circulation to our cells, where it undergoes metabolism, and following metabolism, carbon dioxide is excreted, which is then conveyed by the circulatory system to the lungs, from where which is then excreted and removed by the breathing system. Hence, monitoring of CO2 will help us to reflect alteration in metabolism, circulation, and respiration. So, monitoring of carbon dioxide elimination gives an indication of the patient's metabolic rate. If there is an increase or decrease in EtCO2, it will be a reliable indicator of the metabolism, especially in mechanically ventilated subjects. If it is a spontaneously breathing patient, there will be a compensation of EtCO2 because there will be compensatory hyperventilation of the patient. Now, some of the causes of increased CO2 excretion can be due to increased metabolism. This is seen in increased temperature, shivering, convulsions, malignant hyperthermia, excessive catecholamine production or administration, blood or bicarbonate administration, release of an arterial clamp or tourniquet, or parenteral hyperelimination. Increased exhaled carbon dioxide can result from carbon dioxide, which is usually used to inflate peritoneal cavity during laparoscopy, or to inflate pleural cavity during thoracoscopies, or during arthroscopy, or to increase visualization for an endoscopic vein harvest. Carbon dioxide production usually falls when there is a decrease in temperature or increased muscle relaxation. So coming to the circulation part, carbon dioxide will reflect the cardiac output and pulmonary blood flow as the gas is transported by venous system to the right side of the heart, and then it is pumped back to lungs by right ventricle. As a result, the end-tidal carbon dioxide will decrease when there is a decrease in the cardiac output and vice versa. So, reduction in blood flow to the lungs can result from several conditions like surgical manipulation of the heart or thoracic vessels, a dissecting aortic aneurysm which compresses the pulmonary artery, when there is pulmonary embolism, which can be due to a thrombi, a tumor, gas, fat or marrow, or amniotic fluid, and in hypovolemia. During cardiopulmonary resuscitation, the exhaled carbon dioxide can act as a better guide to give us an effectiveness of resuscitation, which is far more better than what is shown by an ECG, pulse, or blood pressure. The capnometer is also not affected by the chest compressions that we give. Now coming to respiration, carbon dioxide monitoring gives us an information about the rate, the frequency, and the depth of respiration. It can be used to evaluate the patient's ability to breathe spontaneously. It gives a breath-to-breath monitoring, detect bronchospasm, as well as the effect of bronchodilator treatment or altered ventilatory parameters. The use of capnography is dependent on an understanding of the relationship between arterial, alveolar, and end-tidal carbon dioxide. The end-tidal carbon dioxide is the partial pressure of carbon dioxide at the end of an exhale breath, which is usually measured in percentage of carbon dioxide or mm of mercury. The normal values are 5% to 6% of carbon dioxide, which is equivalent to 35 to 45 mm of mercury. EtCO2 is a reflection of the alveolar carbon dioxide in the normal lungs. EtCO2 will provide a clinical estimate of the arterial carbon dioxide when the following conditions are met. That is, ventilation and perfusion in the lungs are appropriately matched, the carbon dioxide is easily diffusible through the alveolar capillary membrane, and there is no sampling errors occurring during the measurement. The difference between the EtCO2, that is alveolar, and the arterial PaCO2 is referred to as AET-PCO2, which is also known as carbon dioxide gradient. This difference is normally 2 to 5 mm of mercury. Conditions which alter the ventilation perfusion ratio or conditions that change the volume or flow of distribution of pulmonary blood flow will affect the carbon dioxide gradient. The examples are when there is a pulmonary embolism, when there is hypovolemia, pulmonary hypotension, etc. Details of which will be detailed later. Now coming to the history of capnography. Capnography was developed in 1943 by Carl Left, and it was introduced into clinical practice in the early 1950s. Collier established the accuracy of rapid infrared carbon dioxide analysis in determining alveoli carbon dioxide concentration. The value of end-tidal sample was established by Rambel. In 1978, Holland was the first country which adopted capnography as a standard of monitoring during anesthesia. According to a study which was conducted by the American Society of Anesthesiologists, about 93% of all the avoidable anesthesia-related incidents could have been prevented with the use of capnography in conjunction with pulse oximetry. In 1998, the ASA Committee on Standards of Care deemed it mandatory that all the patients receiving GA should be continuously monitored for end-tidal carbon dioxide. The Indian Society of Anesthesiologists as well has made capnography a desirable standard in its anesthesia monitoring standards, which was recommended with effect from 30th December 1999. Today, so the utility of capnography has been extended outside the operating room to emergency departments, intensive care units, endoscopic suites, and other procedures. Coming to the definitions, capnography is the continuous non-invasive measurement and graphical display of end-tidal carbon dioxide versus time, which is known as time capnogram, or expired volume, which is known as volume capnogram during the respiratory cycle. Capnograph is the machine that generates a waveform, and capnogram is the actual waveform. Capnometry is the measurement and numerical display of the maximum inspiratory and expiratory carbon dioxide concentrations during a respiratory cycle. Capnometer is the device that performs the measurement and displays the reading. So this is the figure showing capnography and capnometry. Capnography will show you the graph as well as the value, and capnometry will show you only the value of ETCO2. Now there are standard requirements for a capnograph. These include the carbon dioxide reading shall be within plus or minus 12% of the actual value, or plus or minus 4 mm of mercury, whichever is greater over the full range of capnometer. The manufacturer must also disclose any interference with substances like ethanol, acetone, helium, etc., which can interfere with the monitoring of carbon dioxide. Also, there must be an alarm for high carbon dioxide values as well as for low exhaled carbon dioxide. Coming to the physics of carbon dioxide measurement, the methods to measure carbon dioxide levels include infrared spectrography, molecular correlation spectrography, which is also known as microstream, chemical calorimetric analysis, photoacoustic spectrography, Raman and mass spectrography, of which infrared spectrography is most commonly used. So infrared spectrography, a beam of infrared light will be passed through the gas sample, and then the resulting intensity of transmitted light is then measured by a photodetector. The gaseous carbon dioxide absorbs light over a very narrow bandwidth of nearly 4.26 micrometer. Its presence in the sample cell will decrease the amount of infrared light at this wavelength, and that reaching the detector in proportion to its concentration, which is in accordance with the Beer-Lambert's law partially. Absorption spectrum for carbon dioxide partially overlaps with the spectra of other gases which are usually used in anesthesia, like nitrous oxide, water, etc. As a result, infrared filters and compensatory algorithms are used to minimize this interference. Now, depending upon the position of the sensor, the capnograph can be divided into mainstream capnography and side stream capnography. So in mainstream capnography, the infrared sensor will be placed into the circuit. So the carbon dioxide is measured directly from the circuit. As a result, no gas will be subtracted and the response time will be faster. The measuring chamber must be warmed to about 40 degrees Celsius in order to avoid water in the tube. It is usually heavy and requires frequent calibration. It is prone to soiling with saliva or mucus. Coming to side stream, this usually incorporates a pump or a compressor that will aspirate the gas into the sample cell, which is usually located away from the breathing circuit. A fixed volume of the gas will be continuously sampled from the circuit through a nylon or Teflon tubing, which is about 6 feet long. The rate is adjusted to between 50 to 500 ml per minute. Oxygen mask, nasal cannulas, etc. can be adapted in order to allow the carbon dioxide monitoring. Respiratory rate can be monitored adequately. Now, coming to the advantages and disadvantages of mainstream. In case of mainstream, the sensor is present near to the patient's airway. So the response time will be faster. There will be a short lag time, and there is no sample flow to reduce the tidal volume. Disadvantages are secretions and humidity will block the sensor. The sensor will get heated up to prevent condensation. As a result, it can result in facial burns, as The sensor is nearer to the patient end. Bulky sensor is present at the patient's airway, so this can result in kinking of the tube or accidental disconnections. It is difficult to use in a non-intubated patient, and also there are problems with cleaning and sterilization of the sensor. In case of side stream, the advantages are it is easy to connect, the sample line is disposable, it can be used in non-intubated patients with simultaneous oxygen administration via nasal probe. It is also useful in unusual positions like prone position. It is no bulky sensors or heaters are present. Disadvantages are the response time will be delayed, sampling tube obstruction can occur, the water vapor pressure drop along the sampling tube, etc. can affect the carbon dioxide measurement. The sample flow may decrease the tidal volume, which is usually more in case of pediatrics. Now coming to the sources of error, in case of side stream capnometry, water vapor will be condensing in the sample tube, which can be prevented by incorporating filters or water traps, which help to minimize this problem. The response time is delayed in case of side stream capnography, which can be minimized by shortening the tube size or reducing the size of the lumen and high sample flow rates. Calibration should be done at specific intervals, usually at least daily. Modern instruments use a self-calibration process. Coming to the physiology of capnogram, carbon dioxide concentration can be plotted either against time or against volume, which will give us volume capnogram and time capnogram. So, time capnogram. Capnogram has got two important segments, that is inspiratory, which is the phase 0, and expiratory, which is further divided into three phases, that is 1, 2, and 3. And there are two angles, alpha angle and beta angle. So this is the capnographic waveform, a normal waveform. The height will show you the amount of carbon dioxide and the length depicts the time. Capnograph will detect only carbon dioxide from ventilation. No carbon dioxide is usually present during inspiration, so the baseline will be normally 0. So capnograph phase 1, this is dead space ventilation. This is the beginning of exhalation, so no carbon dioxide will be present. The air is usually present from the trachea, posterior pharynx, mouth and nose. As a result, no gaseous exchange occurs, and hence the baseline will be having minimum amount of carbon dioxide. AB shows the baseline. Capnograph phase 1 is the ascending phase or early exhalation. Here, carbon dioxide from the alveoli will begin to reach the upper airway and mix with the dead space air. And as a result, there will be a rapid rise in the amount of carbon dioxide, which will be detected by the sensor. Now coming to phase 3, which is the alveolar phase. Here, carbon dioxide rich alveolar gas will constitute majority of the exhaled air. There will be an uniform concentration of carbon dioxide from the alveoli to the nose or the mouth. So CD shows the alveolar plateau. Now, end-tidal carbon dioxide. At the end of exhalation, there will be the highest concentration of carbon dioxide, which is known as the end-tidal carbon dioxide. The normal value is 35 to 45 mm of mercury. Phase 0, this is the descending phase. Inhalation will begin, oxygen will fill the airway, so carbon dioxide level will quickly drop to 0. DE shows the descending phase of inhalation. Now coming to the angles, first the alpha angle, which is usually present between phase 2 and phase 3, which is also known as takeoff or elevation angle. The normal value is between 100 and 110 degrees. The value is increased in case of airway obstruction and in PEEP. Other factors that will affect the angles are capnometer's response time, the sweep speed, and the respiratory cycle time. Beta angle is present in between phase 3 and the descending limb of capnogram. The normal value is 90 degrees. The angle will be increased in rebreathing, and the angle will be decreased when the slope of phase 3 is increased. Now coming to volume capnogram, this is a plot of fraction of carbon dioxide FCO2 in exhaled gas versus the exhaled volume. It has only the expiratory segment, which is further divided into phase 1, 2, and 3. Phase 1 is the anatomical dead space, phase 2 is the transitional phase, and phase 3 is alveolar gas. So the total area which is found below denotes the FCO2 of a gas in equilibrium, and this can be further divided into X, Y, and Z. a vertical line is drawn through phase 2, which will give us two equal triangles P and Q. The area X represents effective alveolar ventilation, and area Y will represent the wasted ventilation, that is the alveolar dead space, and area Z will represent the anatomical dead space. So Y plus Z will give us the total physiological dead space. So the advantages of volume capnogram are: volume of carbon dioxide exhale can be measured, significant changes in the morphology of expired waveform can be detected, and the dead space can be partitioned into different components of interest. So capnogram carbon dioxide waveform can be analyzed by using 5 characteristics: the height, the frequency, the rhythm, the baseline, and the shape. So the clinical aspects of capnography are: capnography provides 3 sources of information. One, the numbers, that is the PET CO2 value, that is capnometry, the shapes of capnography, and the AET PCO2 differences, that is carbon dioxide gradient. So factors that increase the end-tidal carbon dioxide production are: it can be either an increase in the metabolic rate, that is sepsis, malignant hypothermia, seizures, shivering, hypothyroidism, etc. Or it can be due to a decrease in the carbon dioxide elimination, which may be due to hypoventilation, rebreathing, carbon dioxide absorber exhaustion. Or it can be due to artifact, that is malfunctioning of the carbon dioxide measurement. So the waveform will be regular in shape and the plateau will be above normal. So the conditions normally are: decrease in respiratory rate, that is hypoventilation, when there is a decrease in the tidal volume, when there is increased metabolic rate, when there is rapid rise in the body temperature, malignant hypothermia, laparoscopic inflation, etc. The interventions that we can make to reduce the ETCO2 values are: adjust the ventilatory rate, decrease the respiratory depressant drug dosages, maintain a normal body temperature, and correction of the other underlying causes. Now, factors which decrease the ETCO2 value are due to a decrease in the carbon dioxide production, which can be due to a decrease in the metabolic rate, or due to hypothermia or hypothyroidism. Or it can be due to an increase in the carbon dioxide elimination, which is usually hyperventilation. Or due to a decrease in the alveolar carbon dioxide delivery, which can be due to hypoperfusion, pulmonary embolism, etc. Or due to artificial artifact, which is gas sampling tube leak or loose connection, or malfunction of the carbon dioxide measuring system. So here the waveform will be regular in shape, but the plateau will be below normal. So the most common causes are decreased pulmonary perfusion, hypothermia, hyperventilation, increased tidal volume, decrease in the metabolic rate. The interventions that can be made are to adjust the ventilation rate, evaluate for adequate sedation, evaluate anxiety of the patient, conserve the body heat. Now, if there is an exponential decrease in ETCO2, it can be due to sudden hypotension owing to a massive blood loss, or if there is an obstruction of a major blood vessel, or if there is circulatory arrest, or in case of pulmonary embolism. In case of bronchospasm, the capnograph will show an increased upslope of phase 3. There will be widening of alpha angle. There will be a slower rise in carbon dioxide concentration. And this characteristic waveform is known as shark fin appearance. This can be also seen in case of an occluded artificial airway, presence of foreign body in the airway, or obstruction in expiratory limb of the breathing circuit. Now, if there is a sudden loss of waveform, this can be due to apnea, airway obstruction, dislodged or airway disconnection, ventilatory malfunction, or cardiac arrest. Now, if the ET tube is in the esophagus, we will get a graph like this. That is, initially there may be some ETCO2 value and then it will get tapered off. Now, in case of rebreathing, the waveform will be an elevation in the baseline. Other causes include a faulty expiratory valve, inadequate inspiratory flow, or insufficient expiratory flow. If there is an inadequate seal around the ETT, then there will be a decrease in the plateau phase. So this can be seen in case of a leaky or deflated endotracheal tube or tracheostomy cuff, or artificial airway is too small for the patient. Now, this is known as curar cleft, which is usually seen in the distal 1/3 of the alveolar phase, which usually occurs when there is inadequate muscle relaxation. It can also be seen in case of surgical manipulation of abdomen. Now, cardiogenic oscillations. This is usually seen due to movement of gas in the airway as a result of heart beating against the lungs. We see a sawtooth-like appearance at the end of the expiratory phase. Now, if there is an inspiratory valve malfunction, there will be a prolonged plateau phase. There will be slanting of the inspiratory downstroke, and the inspiratory phase will be shortened, and there may or may not be an elevation in the baseline. In case of spontaneous ventilation, there will be a shorter alveolar plateau. And in case of intermittent mechanical ventilation, intermittent mechanical breaths, it will be interposed with spontaneous ventilation. We will get a short alveolar plateau as well as a normal capnographic wave. Now, if there is an exhaustion of the soda lime, there will be gradual elevation of the baseline and the height of the capnogram will be increased. Now, in some cases, there can be a phase 4. It can be seen in leak in the sampling line during a positive pressure ventilation, which will result in an upswing at the end of phase 3. It is also seen in obese as well as in pregnant patients. They have a reduced FRC and reduced compliance. As a result, the carbon dioxide elimination will be affected. Now, waveform capnography in case of CPR. When adequate or effective chest compressions are given, the EtCO2 will gradually rise and pick up, and finally it will reach a normal value of 35 to 45 mm of mercury. This will indicate adequate circulation. High quality chest compressions are achieved when the EtCO2 value is at least 10 to 20 mm of mercury. The use is evaluating the effectiveness of chest compression as well as identification of return of spontaneous circulation. Now, there can be bifoot capnograms. This is usually seen in severe kyphoscoliosis as well as following a single lung transplantation. This is because the compliance, airway resistance, or the ventilation perfusion ratio in either of the lung are substantially different from the other. Now, if there is a small air embolus which resolutes fast, then there will be a dip in the capnography followed by coming back to the normal shape. Now, if there is a sudden increase in CO2 followed by coming to normal value, this can be due to a release in the tourniquet or unclamping of a major vessel or injection of sodium bicarbonate. Now, conditions which can increase the carbon dioxide gradient as well as decrease the carbon dioxide gradient. The conditions which increase are when there is an increase in the ventilation perfusion heterogeneity, pulmonary hypoperfusion, pulmonary embolism, cardiac arrest, high rate, low tidal volume ventilation, pulmonary disorders, increased age, general anesthesia. In all these conditions, the dead space ventilation will be increased. As a result, the perfusion will be reduced, EtCO2 will be reducing. As a result, the gradient will increase. Now, examples of decrease in gradient are large tidal volume and low frequency ventilation. So, EtCO2 value will be increased. So, the gradient will decrease. And in pregnant women, infants and smaller children, where the FRC is reduced. Coming to clinical applications of capnography, first one is confirming the endotracheal tube placement. Consistent presence of EtCO2 after 4 to 5 breaths indicates a successful endotracheal intubation. There can be false positive EtCO2 value in case of esophageal intubation, which can be due to recent consumption of carbonated drinks, or if there was an aggressive bag and mask ventilation, which resulted in gas entering into the stomach, or when there is a tracheoesophageal fistula. It can also be used in determination of position of double lumen tubes in blind nasal intubation, etc. Second is procedural sedation. Capnographic waveform correlates with respiration of the patient. It gives a breath-to-breath monitoring of the patient. So, when the patient is being monitored with pulse oximetry alone, changes in respiration can go undetected even for up to 5 minutes. Hence, in conjunction with pulse oximetry, capnography should also be used so that a rapid fall in the respiratory rate or any respiratory variations can be found out easily. It can also warn about esophageal intubation, apnea, extubation, disconnections, ventilatory malfunction, a change in the compliance or resistance, airway obstruction, a poor mask fit, or a leaking tracheal tube cuff. Capnography can also be used in the management of patients in whom hypercapnia is detrimental, such as a patient with head injury with raised intracranial pressure, and in pediatric patients with pulmonary hypertension. It can also be used in monitoring changes in dead space. The end-tidal carbon dioxide will be affected by changes in the dead space, which will reflect the changes in pulmonary blood flow as well as cardiac output. When the dead space is increased, perfusion will be decreased. As a result, EtCO2 will be affected and the gradient will be affected. Now, in case of ICU settings, capnography can be helpful in choosing the best positive end expiratory pressure during mechanical ventilation. This is because PEEP will help to reduce the dead space by recruiting more alveoli. As a result, there will be better perfusion and the end-tidal carbon dioxide will be increased. So the gradient will be increased. Non-invasive monitor to assess weaning of patients from mechanical ventilation. Also, it is useful in cardiopulmonary resuscitation. It helps in evaluating the effectiveness of chest compression in identification of return of spontaneous circulation. And also, it can be a predictive indicator about the outcome and survivability of the patient. If the end-tidal carbon dioxide is less than 8 mm of mercury, the survivability percentage is less than 1. And if it is more than 18, survivability rate is more than 70%. Thank you.
Thank you, Dr. Meenu Krishna. You presented it well, and it's open for questions. Sheila, madam, for your comments.
Actually, a few words about volume capnography, which is a new thing. The use of volume capnography is it's mainly useful in ICU settings where you can measure the physiological dead space. And in patients like ARDS, you can set your PEEP value that is at the level of inflection point rather than going above it, which causes increase in the dead space. So by this, using volume capnography, you can adjust your PEEP level, and that will add to the outcome of the patient. And this volume capnography is incorporated in Drager XL ventilators, where there is a built-in volume spirometer, which can calculate the physiological dead space. And also there are metabolic analyzers also, which can give you the value of carbon dioxide, that is carbon dioxide VCO2, and also the minute ventilation, by which you can calculate the fraction of expired carbon dioxide. And when you multiply by 760 minus 47, then that gives you an PE, that is partial pressure of end-tidal carbon dioxide. So VD by VT, you can calculate PaCO2 minus PeCO2 divided by PaCO2 by doing the blood gas analysis. So it is useful in ICU settings, better than time spirogram.
Thank you. Any comments from the senior faculties or questions? Dr. Amit, you are still there?
Much here, and I was just enjoying presentation by two young colleagues of ours, the two postgraduates. I'm really enjoying that. Excellent presentations by both of you. That is there, and good inputs.
Dr. Rajesh.
Yeah.
Yeah, actually, you had mentioned about the burns. Burns, if you keep near the face, the mainstream, like we usually always monitor, does anyone has got that sort of a thing like burns while using the mainstream? If you are using near the face mask, which was mentioned now. Any comments on?
Sorry?
Dr. Meenu,
Any comments on that? Just an experience. Like I wondered because it was mentioned that if you use main, if you near the face, you like there are chances of burns, or like getting it heated up.
Yeah, mainstream. There is a risk. Meenu, can you comment on that?
Because we usually keep this like the main, like if it is side stream is not available, mainstream near the face mask on a regional patient who has been sedated.
There is always a possibility of causing a facial burn. So ideally, that side stream should be used to prevent, or it should be protected. I think so. I haven't used that mainstream.
Okay.
We mostly use side stream only when you are just monitoring the ventilation under the patient on regional or the sedation one. Side streams are being used commonly.
Yes, it's mainly the side stream.
Mainstream, there are two available. Two types are available. Even that metal one and the other one is the plastic variety. May not. I think the metal one may be causing this.
The mainstream nowadays we are mainly using the side stream.
Side stream, yeah. Nowadays,
it can be used for near the patients with the face mask for the sedated patients safely.
Yeah.
Is it available for you, the mainstream analyzer?
Yeah. It is available mainstream.
We are using only the side stream analyzer.
Both are available, the side stream and mainstream.
Difficult to use in abnormal positions, like prone position.
Yeah, mainstream is little heavy also to be used with the circuits only. Yeah.
Because of the weight.
Fixing a mainstream along with the patient's mouth or nose is little difficult. You know, the side stream's a lighter one. You can tape it down and easily you can get the waveforms.
I don't know if there is any advantage of mainstream over the side stream.
There is that time
response time.
Certainly, response time. Response time.
Is it clinically that significant? The response time.
I don't think so. Not like SpO2.
The response time is significant only when we have to check the ventilation. We are mainly using it when you connect it to the ventilator, that is whether the tube is inside the trachea or not. So that is the only time where we need the rapid analysis or the rapid response that we are expecting. In all others, we are using only for ventilation. To assist the ventilation, we are using it for the EtCO2. Because when we use the EtCO2 to confirm our intubation, it will take a little bit of more time. That's the main problem with the side stream analyzer.
One more thing, it is about termination of death or confirmation of death. Like in CPR, what it is mentioned is that if you are getting a terminal rhythm and if it lasts for 20 minutes, there are most likely the patient survival is unlikely. It was mentioned as Meenu has mentioned it also, but they say that if you are getting a terminal rhythm and if it lasts for 20 minutes.
Less than 10, the chance of survival is less.
Yeah, less than 10 with a terminal rhythm and 20 terminal rhythm. And if it is lasting.
As per the AHA guidelines, if it is less than 10, it is the chance of survival is less.
The terminal rhythm, but it is not FDA approved.
Yes.
And definitely in ICU patients, you can clearly see this. You know when the patient will be likely to die also, because it is always moving around less than 10 and with a rhythm like that.
Okay.
Thank you, Paul, for the comments, Dr. Paul.
Rajesh.
Yeah.
Rajesh, shall we conclude?
Yeah, if there is no more questions, can we conclude? We'll over to Dr. Paul.
Yeah,
Amit, thank you.
Thank you so much, ma'am.
Thank you
Dr.
for
Amit,
attending.
Thank you so much.
and the postgraduate
Paul.
student, Dr.
By the way, one thing I
said,
would like to add
Mino.
that Dr. Aishwarya Pilla. Dr. Aishwarya Pilla is I think, first year student in our Kottayam Medical College. If she is the one who answered, I will give her the chocolate.
Okay.
Good one.
Sponsored by ISA Kerala.
Yeah, ma'am. She is the one.
Dr.
It's
Amit.
sponsored by ISA Kerala. Okay, madam.
Aishwarya was transferred from our college, isn't it? From Trishur, she is transferred to Kottayam, isn't it?
Yeah, maybe. I think first it
yes.
just joined. Yeah.
What I can make.
ICU.
What I can make from the conversation is Dr. Aishwarya is going to have hamper of chocolates. ISA Kerala, Dr. Sheila, Dr. Shamshan.
Even from Delhi, it will be awesome.
Yeah, certainly. Yes, I'll be happiest to contribute.
Thank you, sir. Thank you for giving us a very wonderful talk, and like everyone enjoyed your talk, Dr. Amit. And also, you have like very timely. You have stopped it also. It was very interesting. And if you would have seen the attendance at that time, it was not like earlier times. It was quite good, and even during this festive time. And
thank you so much.
To both postgraduates on behalf of ISA Kerala and the head of the department, Dr. Sheila of Kottayam Medical College, for presenting these two topics. And thank you all who are attending this talk and supporting us. Thank you.
Thank you.
Thank you so very much, all of
Thank
you,
you,
and have a very good night. Bye-bye.
Good night.
Thank you so much. Thank you, ISA.
Long live ISA.
Thank you, madam.
Thank you.
Thank
sir.
you,
Thank
Paul.
you so much. It's very nice.
Okay, happy Easter, Sheila.
Happy Easter, Shamshad. Thank you so much. Thank you so much.
Thank you.
Bye.
Okay.
Bye.
Good night.
Bye. Thank you.